Thank you, dear friends, dear colleagues. I'm sorry I use a so strange name I made, but I think it's good stand for my point today. Early activation atrophy syndrome. It means in left heart where is early activated, where will get atrophy. That's my point. As we know, there are many causes of heart failure, but arrhythmias now is well accepted as a cause of heart failure. Atrial fibrillation. Today, focus on desynchrony, especially left bundle branch block. Besides the left bundle branch block, there are many arrhythmia can cause desynchrony in the left ventricle. The synchrony of the left ventricle depends on normal hip system conduction, normal myocardium, and without pre-excitation. Here, I want to emphasize that the activation conduction is very fast inside the hip system. It's very faster than conduction inside the ventricular muscle. The conduction velocity is just 1/4 inside the muscle compared to hip system. The bundle branch block is associated with heart failure. There are many data demonstrated that. Let's review the normal conduction system. The synchrony of left ventricle depends on the normal hip system. When left bundle branch blocked or significantly related, the whole heart activated by his bundle, right bundle, and first activated from right inferior apex site. The whole left ventricle is activated from septal to lateral. The conduction goes slowly through the myocardium. So in patients with left bundle branch blocker, the septal activated first and the lateral activated lately. This is the strain of the left ventricle in patients with left bundle branch block. The red line stands for the lateral. The blue line stands for the lateral wall. We can see in patients with left bundle branch block, the septal wall contraction early, and the septal wall usually occurred before the aortic valve open. So the septal wall, each beat of contraction, the septal wall usually with a very low afterload. That means the septal and the lateral wall covers the whole ejection. This is very good study. Use CAT. We can see the tendon with CAT and the papillary muscle will get free during each beat. This muscle without afterload. 30 days later, the muscle cell gets smaller and smaller, like skeletal muscle atrophy. And if loss of the load, the cell, besides the size decrease, the extensive loss of contractile elements in the unloaded tissue, and many organ can also lose and decrease. I use this cartoon to demonstrate why left bundle branch block can result in the morphology change. This is left ventricle. When left bundle branch when there is left bundle branch block, the septal activated and contract forcefully, and it have no or very low afterload and will get atrophy. When the septal wall during septal wall contraction, the septal wall will push it to the right ventricle. It develop a paradox moment, thinner and paradox moment and ventricular dilation. Of course, resynchronization is the best therapy for patients with left bundle branch block. Besides left bundle branch block, left anterior fascicular block, left posterior fascicular block, and right bundle branch block with left fascicular block, right ventricular pacing, pre-excitation, and high burden premature ventricular contraction has similar hemodynamic changes and can result the ventricle atrophy at the earliest activation area. This phenomenon is demonstrated many years by echocardiologists. But the MRI is very easy to see and easy to understand. This is a patient with early phase of left bundle branch block. We can see right ventricle contractor followed by septal and lateral wall. And the septal wall get a late atrophy, no thickening during systole. But the lateral wall has a good contraction resolve, and the atrophy is less and less from septal to lateral wall, from the earliest activation site to the latest activation site, like this cartoon demonstrated. Heart failure with reduced ejection fraction and left bundle branch block, everyone now is a good indication for a cardiac resynchronization therapy. But some patients respond well to CRT therapy. Some patients don't respond to CRT therapy. There's a popular study in this area, but the most important determinant is the relationship between dilated cardiomyopathy and the left bundle branch block. If the patient is a left bundle branch block induced dilated cardiomyopathy with the correct specific morphology, it will respond well to CRT therapy. If, like the upper two, the heart failure developed before left bundle branch block, so it responds worse to CRT therapy. So it's very easy to determine which patient respond well and not respond well to CRT therapy. This is from a young lady with left bundle branch block. The SPECT imaging showed that the perfusion defect at the anterior septal wall, like a severe ischemia. In fact, it's not ischemia, it's left bundle branch induced atrophy at the septal wall. This highly dilated left bundle branch block resulted heart failure. We can see even the left ventricle is so dilated. The lateral wall is still have good contraction resolve. From longitudinal view, we can see the lateral wall is also with a good construction result. Of course, this patient responded well to CRT therapy. This is a very wise study. After 1 week pacing from right ventricle, the left ventricular ejection fraction decreased significantly. After discontinue the pacing, the left ventricular ejection returned to close to normal. So left ventricular pacing can result in the left ventricular ejection fraction decrease, same as left bundle branch block. This is annual study. Use dog. You can see this left ventricle when pacing from site 2, the epicardium pacing, and 3 months later, the pacing resulted in the pacing site get thinner and loss thickening, whereas the contralateral wall have a good contraction resolve. Similar is left bundle branch block, where is early activated, where get atrophy, and atrophy is less and less from earliest to the later activation site. Left anterior fascicular bundle branch block also can result in heart failure. That's when left anterior fascicular blocked, the left ventricular is activated from inferior wall. So the left inferior wall will get activated early. The anterior lateral wall will activate and contract later. So for patients with left anterior fascicular block, the inferior septal will get atrophy and will contribute to heart failure. For left posterior fascicular block is similar. Right bundle branch block with wide QRS is also a class 2 indication for CRT therapy. But some patients respond well, some patients don't respond to CRT therapy. Why? Because some patients with left fascicular, if right bundle branch block or compounded with fascicular block, the left ventricle is in disynchrony, will respond well to CRT therapy. If there is no left fascicular bundle branch block, will not respond to CRT therapy. It's very easy to understand. This is right bundle block with left anterior fascicular block. So the EKG is a right bundle branch block with left anterior block. We can see the inferior lepto contract early, and the superlateral contract laterally is in disynchrony. Thus, the central picture is right bundle branch block with left anterior fascicular block. The activation mapping clearly see the left anterior wall is significantly dilated. So the left ventricle is in disynchrony. For this patient will respond well to CRT therapy. For the left one, just the right bundle branch block. The left ventricle, there's no disynchrony in left ventricle, and this patient will not respond to CRT therapy. Pre-excitation, result in heart failure is not accepted by cardiologists. In fact, pre-excitation can also result in left ventricular desynchrony, because some segment of left ventricle will activated and contracted before the whole left ventricle is activated by his Purkinje system. This is our own patient, a 11 years old girl, we can see this patient has a right-sided accessory pathway type B pre-excitation. The accessory pathway is located at the 12 o'clock of tricuspid annulus. We can see the left ventricle is in desynchrony. Septal wall contracted early and followed by lateral wall. So the left ventricular is significantly desynchronized, and thus we can see the atrophy close to the accessory pathway and paradox moment. 6 months after ovulation, the desynchrony disappeared. The septal and the lateral contract simultaneously. Thus, the strain. There's a strain of left ventricle, ultrasonic strain of left ventricle. We can see that the segments contraction paradoxically and in very chaos contraction. After ovulation, after disappear of the accessory pathway, the 6 months later, the left ventricle returned to synchrony completely. So pre-excitation, especially accessory pathway close to septal, can result in significant left ventricle desynchrony. Of course, will contribute to heart failure. This MRI image of this patient, we can see this picture very like a left bundle branch block induced heart failure. 6 months later after ovulation, the activation close to simultaneous. This own study demonstrated that pre-excitation can result in the decrease of left ventricular ejection fraction, and the ejection fraction will return to normal after catheterization. The many scenarios can result in desynchrony in left ventricle, not just the left bundle branch block. Left bundle branch, right ventricular pacing, high burden ventricular premature contraction, pre-excitation, left anterior fascicular block, left posterior can result in left ventricle activity not simultaneously, where usually there is some area activity early, some segments activity and contracted lately. Of course, it will result in where early activity will get atrophy, where later is activated, where the contraction resolve is well, and the atrophy is less and less from early activation to the latest activation site. That's my last slide. All the things I mentioned in the last slides, all the arrhythmias, left bundle branch block, right ventricular pacing, fascicular block, and right bundle branch block with fascicular block, pre-excitation, PVC, VPC can result in desynchrony in left ventricular and contribute to heart failure, and with a very specific morphology change. So I use a strange name, early activation atrophy syndrome. I'll stop there. Thank you.